Just give you a little bit of background first about bone disease in HIV. And what we do know is that antiretroviral treated patients have an increased risk of osteoporosis and of fragility fractures. We also know that when an HIV positive patient starts antiretroviral therapy for the very first time, they lose up to 6% of their bone mineral density over 48 weeks, which then tends to stabilise, although there is some conflicting data about how that stabilisation remains, with other studies suggesting that perhaps there is continuing lower loss of bone mineral density. We know that there is different effects of different classes of antiretroviral drugs, with the nucleoside analogues, in particular tenofovir, and the protease inhibitors being associated with greater loss of bone mineral density. Raltegravir, or the integrase inhibitors, is really unknown what their effect on bone mineral density is. The second-line study provided an opportunity to examine changes in bone mineral density in patients who were virologically failing their first-line regimen. Second-line compared the WHO recommended second-line regimen of 2 to 3 nucleoside analogues plus lopinavir ritonavir, or a nucleoside-sparing regimen with raltegravir and lopinavir. The bone sub-study of the second-line study was performed at 8 sites in 5 middle-income countries. The countries had to have access to DEXA scanning to participate in this study. So 210 patients had DEXA scans at study entry and again at week 48. The study recruited 52% women and 97% were non-Caucasian. And this is very different to most bone mineral density sub-studies that have preceded this second-line bone sub-study. The median duration of the first-line regimen was 3.4 years, and tenofovir had been used in 17% in their first-line regimen. Also at study entry, 1/3 of patients had low bone mineral density at the spine already, and 21% had low bone mineral density at the hip. So what were the results? What happened at 48 weeks? And if we look at the reduction in bone mineral density at the hip and then at the spine in the group that were randomised to the 2 to 3 nucleoside analogues and the protease inhibitor, lopinavir, patients in that group lost 5.2% of their bone mineral density at the hip and 4.2% at the spine. This is in contrast to the group that were randomised to the raltegravir and lopinavir. They lost 2.9% of their bone mineral density at the hip and 2% at the spine. And this was a significantly different loss, so that the raltegravir arm had the least bone mineral density loss. There was no significant difference between the arms for development of new osteoporosis or low bone mineral density. And when we did a multivariate analysis of predictors of those that will lose the greatest amount of bone mineral density, it was use of tenofovir in the second-line regimen plus a lower body mass index at baseline that were predictive of greater loss at both hip and spine. So what's important about this study? This is the first study that has examined changes in bone mineral density in patients virologically failing their first-line regimen. And the magnitude of the loss of bone is similar to that seen in antiretroviral naive patients who initiate therapy, which is quite different to patients who are suppressed on their regimen and change their antiretrovirals for toxicity or other reasons. As I said, the loss of bone mineral density was least in the raltegravir and protease inhibitor arm. And this study's really provided confirmation that loss of bone secondary to antiretroviral therapy remains a significant comorbidity in the long-term management of HIV.